Good evening, everyone. Welcome, and thank you for attending our Ahead of Cancer lecture series this evening, sponsored by the Allegheny Health Network Cancer Institute. My name is Tanya Behel, and I'm a project manager for the Cancer Institute. There are a few housekeeping items that we want to review before we start. During the presentation, all participants can type questions into the chat or Q&A portion of the Zoom. We will be addressing those questions at the end of the lecture if time allows. Participants are not able to speak during the conference, but again, we encourage feedback via the chat option. Tonight, we are excited to welcome Dr. Colin Champ, who will be speaking about how nutrition and exercise impact cancer growth. Dr. Colin Champ is a board-certified radiation oncologist, diplomate of the American Board of Integrative and Holistic Medicine, and a certified strength and conditioning specialist by the National Strength and Conditioning Association. He came to Allegheny Health Network from Duke University Medical Center, where he was an associate professor in the Department of Radiation Oncology. His research focuses on both cancer treatment with radiation therapy and the interaction of nutrition and exercise in cancer prevention and treatment. He is also director of integrative oncology at AHN and head of the AHN Cancer Institute Exercise Oncology and Resiliency Center at AHN Suburban Hospital. Welcome, Dr. Champ.
Thank you. Thanks for having me. Can everyone see my slides? No issues? Okay. Thanks again for having me. So that picture in the background is our Exercise Oncology Center, where many people come and exercise very vigorously, very intensely, and I'll discuss that towards the end. This topic in itself could be a 2,000-page textbook, so in 30 to 40 minutes, I'm going to try to go through it as quickly as possible. I'll hit the high points. Things that I don't talk about are usually those areas where there's not a lot of research, but happy to answer questions on topics I don't discuss at the end. These are my financial conflicts, and that's bone broth and kimchi in the background, which is the perfect breakfast. So how nutrition and exercise impact cancer growth. I'm going to discuss cancer treatment, and I put that in quotes, through nutrition, targeting the soil versus the seed, what dose, and that's both in terms of nutrition and exercise. And this is an area where in medicine, you always think about what dose is adequate, but oftentimes in nutrition and exercise, we forget about how important dose is. And tangible takeaways, with a typo there, I apologize. So looking at how nutrition and exercise impact cancer, I always compartmentalize it to two ways. And it's whether we think we're stopping the seed from growing. And on the left here, this is San Lorenzo dei Bellizzi, where my family is from in Italy. And you see this grapevine growing. There was literally 2 square inches of soil below this house, and this grapevine grew out and spread. And that's kind of like the seed growing. That's a cancer cell that shouldn't be there. Granted, that's a beautiful picture and a beautiful growth pattern. So maybe I should use an uglier picture in the future. Versus the soil, and that's on the right. And this is from Puglia in southern Italy in the Heel, where this soil is so fertile that you have these giant olive trees growing, over 15 feet tall, and nothing between them at all, but this little patch of perfectly manicured flowers. So this is where we actually help the soil to stop cancer growth or weed growth by nourishing the soil. So on the left, we think we're stopping the seed growth. On the right, we're just nourishing the soil to allow the right seeds to grow. And I'll dig a little deeper into that. Anytime we talk about nutrition, exercise, but certainly nutrition, I just have to hit on a couple points here, because we all have to eat. There's quite a bit of studies out there that are far from satisfactory, that go on the nightly news and would scare my, God rest her soul, 96-year-old grandmother, who would worry all night and call me the next morning because I do something that KDK told her would cause cancer. We always have to consider, when we think of population studies, i.e. studies that look at a group of people and say, does something cause or decrease the risk of cancer? This is the first study really looking at that. And this was a big study by this man who was knighted, Sir Richard Dahl. And he, with Bradford Hill, looked at the mortality of doctors who smoked. So they basically looked at a bunch of doctors that smoked cigarettes and a bunch of doctors that didn't smoke. These were huge numbers, tens of thousands of people. And what they found was those individuals that smoked had a 40 times risk of getting lung cancer. I will say the risk of lung cancer is so low that overall that risk was only 16%. So of 100 people that smoked, 16 got lung cancer. That's still a large number. I'm obviously not recommending smoking, but even sometimes something as high as a 40 times risk of getting something can still be a low absolute number. And on the bottom there, those hazard ratios, this would be a hazard ratio of 40. Okay, so keep that in mind. Not 1, not 2, not 3. Hazard ratio of 2 would be double the risk. Hazard ratio of 3, triple on and on to 40. For heavy smokers, there was a 3,000% increase in risk of tobacco. So these are huge numbers. Those numbers basically set the tone that if you smoked, you had a higher risk of cancer. Because that risk was so high, you could not argue with those numbers. All right, keep that in mind. 40 times risk, 3,000%. He went on to then publish a study looking at environmental factors and cancer incidence and mortality in different countries around the world. And the three main findings that got airplay were an association between stomach cancer and fish. So people that ate fish, particularly in Southeast Asia, had a higher risk of stomach cancer. People that drank coffee had a higher risk of kidney cancer. And people that ate more fat had a higher risk of breast cancer. These hazard ratios were not 2, 3, or 40. They were the numbers below. These low, so 1.01 could be a significant study that KDKA can air and scare my grandma that she doesn't sleep well. But the actual increased risk of cancer can be utterly minute, so tiny. So Dahl, who's a responsible statistician, said there may be associations, but there may be other factors that are leading to these. Another thing we need to remember is associations only mean associations. They don't mean that something causes something. They just mean that people that do a lot of one thing may also get a lot of another thing. So people that ate a lot of fish got a lot of stomach cancer. What they did find was that there was preservatives in the fish. It wasn't the fish themselves that were causing stomach cancer. But that's a side note. Sorry. So we'll come back to this study. But on the heels of his tobacco study and then this study showing potential association with our food and cancer comes Walter Willett and the group at Harvard. In 1987, this is a bit of a busy slide. They looked at 90,000 nurses aged 34 to 59 without cancer. And then they looked at those women, those nurses that got cancer versus those nurses that didn't get cancer. And they wanted to look at dietary fat. So they wanted to replicate the last study. They found no relationship between dietary fat and breast cancer. And that says association between fat and breast cancer. That is dietary fat. There is an association between body fat and breast cancer. What they actually found was that fat in the diet trended with a lower risk of breast cancer. So the exact opposite of what they're looking at. More women eating more fat had a lower risk of breast cancer, but it trended, and that was only an association. So it is certainly not appropriate to say that eating dietary fat lowers your risk of breast cancer. They found nothing. In 1996, almost a decade later, there was a pooled analysis of an additional 6 studies looking at dietary fat and breast cancer, almost 340,000 women, and also found that fat in the diet was unrelated to breast cancer risk. The group from Harvard in their initial study said perhaps the follow-up wasn't long enough, and if we simply follow these women longer, we'd see the association. In an 8-year follow-up of the same study, they found that both dietary fat and fiber was unrelated to breast cancer risk. And then later, when they looked at a 14-year follow-up, if you read the study, or at least if you read the abstract, they'll say there's no association. They actually found that women that increased their dietary consumption of fat by decreasing their carbohydrate consumption by 5%, i.e. they swapped out carbs in their diet and instead ate fat, like my daughter Kiara on the right, who just polished off that steak, they had a decreased risk of breast cancer by 4%. So there's a lot of numbers there, but again, they basically found the exact opposite. As a side note, it's interesting, people always show red meat when they talk about fat, and that's actually a pretty darn lean piece of meat. So there's not even that much fat on it. I just wanted to put a picture of my daughter in. Even Walter Willett, who really pushed hard to convince himself and the public and the scientific committee that dietary fat was associated with breast cancer. In 2012, he even said there was never any strong evidence for this idea, but it was repeated so often that it became dogma in the 1980s and 1990s. And I'm saying all this because it's still dogma. And when we talk about ways that nutrition can interfere or interact with cancer, everyone always gets scared if we discuss eating fats, then they eat a bunch of carbohydrates, which his data showed the exact opposite effect. That's my daughter eating Florentine tripe, which if you haven't had is one of the most amazing dishes in the world, and she loves it. And this is how bad ideas start, through population studies. And so Walter Willett, his crew up there in Harvard, followed this study actually around the same time as that study, 1985. They ran a prospective study on postmenopausal estrogen therapy and coronary heart disease. So what they did was look at a large group, again, of nurses in the Nurses' Health Study, of 122,000 nurses aged 30 to 55. They looked at, if you look at adjusted for tobacco, diabetes, hypertension, cholesterol, if their parents had a myocardial infarction, a heart attack, oral contraceptives, et cetera. What they found was women that were on hormone replacement therapy, so estrogen, postmenopausal women on estrogen, this was associated with a 50% reduction in coronary artery disease. And those women that were currently on estrogen had a 70% decreased risk. What they said in their study, and if you look at the far right here, and I don't think you guys can see my mouse that I'm moving around, on the far right, it says these data support the hypothesis that the postmenopausal use of estrogen reduces the risk of severe coronary heart disease. So that is absolutely incorrect. What these data support is that there is an association between estrogen use and coronary heart disease. This data does not say that if you take postmenopausal estrogen, it lowers coronary heart disease. That needs to be a randomized study. But regardless, in 1985, I was actually 5 years old, so I have to watch what I say, but I'm sure the media had a blitz about this study, and people, doctors, physicians started prescribing this because lots of patients started asking for it. And rightly so, the physicians read this study saying if you give women postmenopausal estrogen, it will reduce their risk of severe coronary heart disease. Only in 2002 did they actually publish a randomized study where they gave half the women on study HRT, hormone replacement therapy, and they gave the other half a placebo. What that study showed was that women that got hormone replacement therapy not only did not have a decreased risk of coronary artery disease, they had an increased risk. They had an increased risk of heart disease, breast cancer, stroke, pulmonary embolism, and total cardiovascular disease. So the exact opposite of what their initial study showed. The only thing they had a decreased risk of is hip fracture, which is why if you or a family member has breast cancer and they're on Arimidex, we talk about at the gym hip fracture all the time because blocking estrogen can weaken your bones. So basically what they found was the exact opposite. And this is exactly what you don't want. You don't want medical decisions being made on population studies that aren't correct. So what happened in this study? Why did women on estrogen therapy have a decreased risk of coronary artery disease? It's called healthy user bias. It had nothing to do with hormone replacement therapy. What it had to do with was women like this who exercise a lot, apparently do yoga and smile a lot while they're doing yoga in a pretty cool studio with a brick background in the wall, and that wear Lululemon and other exercise gear, that exercise a lot, felt pretty crummy during menopause, so they went to their doctor. So that's what happened. Healthier women went to their doctor and were then put on estrogen. When they randomized these same women to estrogen or no estrogen, again, there was no benefit. That's called a healthy user bias. We see it all the time. We see it in anti-fat studies. We see it in all these studies where they say people that do this have a lower risk of this type of cancer. But the question really is, the reason they're doing that is because they do a bunch of other healthy things. And in the words of Mark Twain, there's three kinds of lies: lies, damn lies, and statistics. When you hear about a study that shows that this is correlated with cancer, or bacon causes pancreatic cancer, et cetera, there should always be four things you look at. Are there population studies to support it, like the Willett studies we just discussed? That's the intro. If there are some, that doesn't answer anything. That means there may or may not be something. We need a lot more mechanistic support. Does it make sense? Like the estrogen study didn't really make a lot of sense. Are there animal studies to support it? So were there mouse studies, et cetera? And then last, are there randomized human studies? even Dahl, after his study, or during his study, if you look in the conclusions, that fat, coffee, and fish study, he said that the associations may reflect some other variable correlated with economic development. People that ate a lot of fat around the world at that time were generally more obese because they were wealthier and they were living a Western lifestyle, which we know what happens when you live a Western lifestyle. The quality of cancer incidence data is affected by economic factors, particularly as controlling for any of the food consumption variables can reduce this correlation. So people that weren't overeating, regardless of what they were eating, didn't see that increase in breast cancer. And he cautioned that the association between breast cancer and obesity makes further calculations difficult. Obesity is correlated with breast cancer because adipose tissue secretes all kind of nasty hormones that can lead to breast cancer. We'll talk about that later. And when in risk or when in doubt, turn to this paper. This is actually by a radiation oncologist. So big props to him. He and a statistician looked at the Boston Cookbook, at all the ingredients in the Boston Cookbook and all the studies looking at those ingredients in cancer, and they found that everything we eat is associated with cancer. If you look at the top, wine, they're mostly on the left of that line. That's a hazard ratio that's less than 1. That means it may be associated with a lower risk of breast cancer. If it's above that 1, it may be associated with a higher risk. If you look at those numbers on there, those are hazard ratios. You see 1, 2, 5. There's a 10 there for bacon. But remember in that lung cancer study, there was a 40, right? So these are nowhere near there. If you look, I mean, it gets silly, right? Wine may reduce your risk. It may increase it. Tomatoes, there's some tomato studies that increase your risk of cancer. Tea could increase your risk of cancer. Sugar's generally on the bad side. Salt's pretty bad. There's absolutely no mechanism where salt would increase your risk of cancer. Coffee is mixed, which, you know, these studies tick you off because if you like coffee, you obviously want it to be on the good side. But the point of this is they're all silly. And what happens is, if you see on the right here, we're looking at this gray dot, right? We're focusing in very closely on food, and we're missing the big picture. So this is a picture of Orvieto, a beautiful city that if you sit back on the mountains and overlook, it's wonderful. But if you focus in on that little gray dot, you kind of miss everything. And that's what we're seeing over and over again. And statisticians, researchers, they're partially to blame, right? We make bold statements in these papers. KDK picks up on it, and again, they're scaring my grandma so she can't sleep at night, and then calls me at 7 o'clock the next morning about these studies, telling me I shouldn't drink coffee anymore. Mechanistically, this gets a bit complicated. This will be my most complicated slide, but realistically, if you want to look at the way food could interact with cancer, either cancer incidence or cancer treatment, there's 4 main mechanisms. And there's a reliance on glycolysis, number 1 on the top left, of cancer cells. And what this means is that cancer cells do like to use sugar. That doesn't mean you can necessarily starve a cancer cell by not eating sugar. You hear this a lot, like, does sugar feed cancer? It's sugar, and it's those pathways. So glucose, sugar, insulin. Insulin's a hormone your pancreas secretes when your blood sugar goes up. IGF-1 is insulin-like growth factor. These bind to receptors on here, and they upregulate this. It's called AKT and mTOR, and they basically increase cell growth, damage repair of cancer cells, and cancer survival. So there are always cells being damaged in our body, and our immune system should take them out. If our immune system doesn't take them out, they could turn cancerous. So increasing this insulin and glycolysis pathways can do that. So through the diet, if we could cut that off, that would help. You can't lower your glucose levels in your body below a physiologic level. You can get them pretty low. If your glucose is generally high, i.e. if you have prediabetes or diabetes, changing through your diet to lower glucose via association study is associated with a lower risk of cancer, and likely mechanistically may improve cancer treatment, but we haven't proved it in a randomized study. Number 2 is AMP kinase on there. If you see that AMPK, and this is my favorite one because this points directly to nutrition and exercise and what we can do. This is a cellular energy currency meter in our cells. So basically, anytime our ATP, which is our energy currency, is low, it sounds the alarm. One of those alarms is that yellow thing in the middle, NRF2. And what's pretty cool about this is spices, cruciferous vegetables, berries, exercise, maybe polyphenols in red wine, though I'm probably not supposed to promote red wine consumption, but there is polyphenols in red wine that promote that, as does fasting, resistance exercise, carbohydrate restriction, a ketogenic diet. Those all increase AMP kinase. They decrease the they increase the energy currency deficit. The cells push the panic button. They block those same pathways to the left that can increase cell growth, damage, cancer cell repair, and survival. And then the other thing they do is they ramp up our mitochondria, which actually make free radicals. And if you follow this straight down, that ROS surrounded by red, and our cells make antioxidants. So you've probably heard about antioxidants and how they're so good for us to eat in our diet, etc. That's all controversial. What is good is for us to promote our own innate antioxidant mechanisms. And that's number 3 on there. And that's through oxidative phosphorylation. That improves mitochondrial function. And mitochondria are actually what help assassinate cancer cells or faulty cells in our body that could lead to mischief. So ways to improve mitochondrial function and upregulate AMP kinase, in theory, could help us to prune our bodies of cancer. And again, that's through those mechanisms I just mentioned. And then number 4, this is back to the soil, and that's body composition. So if you increase muscle, decrease fat, increase bone density, lift heavy weights, lift weights to a degree where you tear muscle mass so that your muscle mass grows back bigger. If you don't tear muscle mass or cause enough stress that you need to accommodate those changes, you won't see improvements. So getting out the 1-pound dumbbells that my daughters can lift, unfortunately, are easier, but it's probably not going to get the benefits that we want to see. We want to tear up our muscles so much that they start secreting this thing called muscle-derived IL-6. And then at the bottom of all of this, metabolic stress, whether that's through our diet, nutrition, eating a Indian dish with turmeric in it, it promotes physical and cellular differential responses by sounding the cellular alarm. It tells the body there's stress, even though there may not be. All right, that was a long slide. I hope you're all still with me and not asleep. So in terms of nutrition directly affecting cancer cells, we do have data on that, and that data is over 100 years old. We don't have data in humans still. These are hard studies to run. On the top left here, this is a study that was done at Cornell, again, over 100 years ago. They implanted tumors in mice. Mice are not humans. And what they found was when they cut carbohydrates in a stepwise fashion and got to 0, the tumors actually stopped growing. They made some bold statements. They said there's seems to be no reasonable ground for doubt in view of these experiments that a lack of carbohydrate in the diet produces such an influence upon the rats as to make them more resistant to tumor growth. And when the diet includes carbohydrate, the tumors grow luxuriantly. When the diet does not include carbohydrate, the animals show a marked resistance. That's because of that insulin glucose pathway. Does this hold in humans? We don't know yet. We've looked at it, and we continue to look at it. And on the top right here, this was Albert Tannenbaum, who really ran the most studies looking at mice and food consumption and cancer. Again, these are mice. What he found was if you cut calories in the mice, they actually had decreased risk of tumor growth. These were in models where he was inducing tumors, so skin tumors, a mouse model where the mice got spontaneous breast cancers. What he found, and this is in red here, was those mice that he constricted carbohydrates had the most significant decrease in cancer incidence or cancer growth. So much like what Van Alstyne and Beebe found 100 years ago. On the bottom left here, Herbert Grace Crabtree found the same. He found that cancer cells behave very similar to bacterial cells and also yeast cells, and they had a propensity to take up sugar. He actually found the Crabtree effect, which explains why yeast eat the sugar in grapes and make alcohol. And so vintners still use that, the Crabtree effect, to make wine. And then on the bottom right, the same guy found that if you decreased glucose available to cancer cells when we were treating them with radiation, it actually improved the effect of radiation. There's a decent number of preclinical studies showing that. We still do not have any studies in humans where I could tell you that if you cut carbohydrates, it's going to make your treatment work better. But I'll give you my views on carbohydrates shortly. In terms of the soil, so that's the seed, right? That's how we could stop the seed in theory from affecting those pathways. How do we improve the soil? So the two best ways to improve the soil through nutrition and exercise is increasing muscle mass and decreasing adipose tissue. When we think of muscle mass, we think of muscle mass as being purely a mechanical organ that helps us move, helps us stay off the floor, keeps us strong. It's more than that. Your muscle is an organ. And if you lose muscle throughout life, it actually correlates with worse overall survival. So people that maintain muscle live longer because muscle is an organ. It's just like if you lost half your liver, you know, you may have issues. If you lost a kidney, you have to be careful about certain things. That's how we have to start viewing muscle. The other thing with muscle is when it's contracted, it actually secretes a bunch of hormones. So if you look at the left, and I hope your screens are enlarged, if you look at the left, there's a million hormones that come out of muscle, particularly muscle-derived IL-6, and this is what happens when we resistance train and tear the muscle. That IL-6 comes out, it helps you burn fat, it helps increase bone density, helps the GI tract be intact and healthy, it helps insulin sensitivity in the pancreas, and it helps, if you look in the middle here, it helps macrophages, lymphocytes, neutrophils, it helps our immune system to function. We need a healthy immune system to attack cancer cells, whether we are diagnosed with cancer or whether we're trying to prevent cancer from happening or whether we're trying to prevent cancer from occurring. Muscle is vital in that. So we want muscle mass. We want to have as much muscle mass as possible. And we want to exercise it and stimulate it so that it secretes hormones that function, help our body function. Adipose tissue, on the other hand, can keep us warm. And it serves a function. I'm not saying we should have zero adipose tissue, but it also, instead of stimulating the immune system, it actually causes immune dysfunction and it causes insulin insensitivity. All right. I hope everyone can see this now. Sorry, I just checked out the chat for a second. All right. Now, and we know, for instance, with breast cancer, which I'll stick with because that's my specialty, we know that body composition correlates with outcomes after treatment for breast cancer. This was in a study of 3,200 stage 2 and 3 breast cancer, women with stage 2 and 3 breast cancer, treated for cure, of course. What they found was on the left here, when you did a CT scan and looked at the muscle mass on these women that were sarcopenic, the orange line, i.e. had low muscle mass, had a significant reduced survival, basically immediately after treatment and at 10 years, which was the follow-up of the study. Women that had less radiodense muscles, i.e. not as healthy muscles, also had a lower survival. And adipose tissue on the far right here was the opposite. So that Carolina blue line showed an improved survival compared to the orange line. Carolina blue was the lowest amount of adipose tissue, whereas the orange was the highest amount. And you see this again and again. You basically see this in every type of cancer: prostate, pancreatic, colorectal. You see this again and again because, again, muscle mass serves a vital function, whereas fat mass and excess can lead to inflammation and hormone secretion, etc. If you think you're going to calorie restrict off that extra fat, you'd be wrong. And there's 29 total studies. These are breast cancer studies where they had women undergo calorie restriction. And this ranged from 500 to 1,000 kilocalories per day, which is insane. This is the standard of what people recommend. It's really never even been tested. And only 4 of those studies even came to a conclusion. And I was part of one of the study. The reason they didn't come to a conclusion was because everyone on the study dropped out or stopped showing up, because 1,000 kilocalorie per day calorie restriction is impossible. It is impossible to do. So you just drop out. So there has to be better ways to do it. And there are other things. There has to be better ways to do it to preserve muscle mass. So in terms of nutrition and the randomized evidence, this study was on the far right here. This was a decade of studies comparing low carbohydrate, calorically restricted, so restricting calories like the last slide, diet versus a low, I mixed that up. The blue is a low carbohydrate, calorically unrestricted diet. These individuals could eat as much as they want. The gray is a low fat, calorically restricted diet. So most of these, it's 1,500 calories and you had to cut fat. What the studies unanimously show is significantly more weight loss on a low carb diet that tells people they can eat as many calories as they want. So if you're put on one of these 2 diets, you're going to lose more weight on the low carb diet. And it makes sense because cutting calories is quite difficult, or purposely cutting calories is quite difficult. In terms of randomized trial victories, this was from 2 years ago, so it may be updated at this point if there's new studies. Frankly, I stopped paying attention because there's almost 60 studies randomizing individuals to a low carb, calorically unrestricted diet versus a high carb, low fat, calorically restricted diet. And the low fat diet has never been better than the low carb diet. They've tied half the time, and half the time the low carb diet is better. So at the Exercise Oncology Center, we generally recommend a low carb diet because that's what the data shows works, right? That's evidence-based right there, randomized studies. We do have some studies in individuals undergoing cancer treatment looking at a ketogenic diet. This was a study in 45 women with endometrial or ovarian cancer. They're both studies that can correlate with obesity and studies that show if you lose weight, if you lose adipose tissue, you can have improved survival. They randomize women to if you see the pie chart there, very high fat, 70% fat, 25% protein, 5% carbohydrate diet. I'm not recommending this to anyone on the call. They were just looking at a very low carb diet to make a point versus the American Cancer Society diet, which is a low fat, high fiber, cardboard diet, which is really pretty darn hard to follow. And I don't know anyone that actually successfully follows that. People try to and they fail and then they feel bad about themselves, but don't feel bad about yourself if you fail that diet, because we all have failed that diet. What they showed in this study that was also randomized was in terms of adipose tissue, that's on the top left corner here, women on the ketogenic diet had significantly less adipose tissue in terms of pounds by the end of the study versus women on the American Cancer Society diet. In terms of visceral fat, below that, women on a ketogenic diet lost 22% of their abdominal fat by the end of the study. That's a significant drop. Women on the American Cancer Society diet lost 4%. And then central adipose tissue, was significantly low in the ketogenic diet. And the bottom right here is key. Fasting insulin, remember that pathway? We talked about the insulin pathway. Fasting insulin was significantly lower in women on a ketogenic diet than in an American Cancer Society diet. So this is telling us that it's not about calories, it's about what we actually eat. And again, if we go back to this pathway, there's no calorie receptor on the cell, right? There's insulin, glucose, there's AMP kinase, et cetera. And that's what this study showed us. We looked at a ketogenic diet. This is with Leopoldina in Germany. We've done a couple studies with them. We looked at a ketogenic diet versus standard cancer diet in just over 60 women with breast cancer. I'll be quick on this one. We basically found the same thing. On the far right, far right in orange, women on the ketogenic diet lost significantly more fat mass than women on the control diet. Fat-free mass, women did lose a little bit of muscle mass, so that's concerning, but it was not that much when you look at the skeletal muscle mass. And then in terms of body water, it wasn't just water weight. This was actually adipose tissue weight. So the ketogenic diet is a good way to lose fat. It's very difficult as well. So I'm not saying anyone on this call needs to go on that, but it just tells us when we think about macronutrients, they're not all the same. What we actually recommend at the Exercise Oncology Center is based on another randomized study by Chris Gardner out in Stanford, where women lost 12 to 13 pounds at 1 year. They put women on a low carb versus a low fat diet. In actuality, neither one was exactly that. The low carb diet was about 115 grams per day. We generally recommend less than 100 if you're trying to lose adipose tissue. The keys with what we recommend and what they had on the study: number one, no calorie counting, eat nutrient dense foods. Number two, limit processed foods, sugar, bread, pasta. So we actually have women limit their grains. Cook and eat with your family, no snacking. Eating is a social time. You're not supposed to be doing it in your car. If you're not making enough time in the morning to cook breakfast, then don't watch 3 Golden Girls episodes at night and then go to bed an hour and a half earlier. And then number 4 is eat whole foods. So we don't subscribe to this don't eat meat, or no, eat grass-fed meat, eat high quality meat, cook it appropriately, don't burn it, etc. Because not all foods are the same, and this is where we've been simple-minded in the medical field. If you look on the far left here, this is a number of omega-3s, the percent of omega-3s of total fat in beef based on days being grain-fed in the feedlot. So you see 3% of fat is omega-3s. If you put cows on a grain-fed diet for almost 200 days, those omega-3s are gone. That's the same food, right? How can you tell someone don't eat beef if this beef at 196 days is very different than the beef that's grass-fed? If you look on the right, same thing. All pasture-raised cows, if you look at dairy from them, the omega-6 to omega-3 ratio is 1 to 1. That's what it is in nature, right? That's perfect. That's what our ancestors ate. That's what hunter-gatherers ate. As soon as you start pulling the pasture out, 2/3 pasture, you see the inflammatory omega-6s rise. A third pasture, you see the omega-6s go through the roof. This is beef that's raised in Japan versus beef that's raised, and that's my daughter who just ate another Florentine tripe. Now she's moving on to the vegetables, as you see there. In terms of beef, in the US, this is different estrogens in beef. Estrogen correlates with many cancers, right? There's many estrogen-driven cancers. Breast cancer is obviously one of them. Look at the amount of estrogen in beef raised in the U.S. versus beef in Japan, because they don't shoot their cows up. They don't try to fatten them up. Their cows roam around. But these are two different foods, right? If you eat beef in the U.S. or you eat beef in Japan, they are two different foods. And you could extend this to PAFs or PFAs in the water that's vegetables are grown in, et cetera. If you look at vitamin E, vitamin A, beta carotene in the dairy of cows that are pasture fed versus given stored hay, you see the same thing. You see it drop off. Same thing on the right in terms of grain and hay, 33% pasture, 66% pasture. 100%, you see much higher amounts of conjugated linoleic acid. Sorry, I didn't list that. On the far right, that's conjugated linoleic acid. It is an anti-inflammatory fat that's in dairy that your fat cells take up, and they help fight inflammation, which can help fight cancer. Your breast tissue is full of fat, so guess where that CLA goes when you eat it? It goes right to the breast tissue. They actually have experimented in humans and confirmed that. All right, we're getting close here, so I'm going to have to speed up. And this is maybe my favorite study. They gave individuals 10 weeks of a half pound of pecorino cheese a week. What an awesome study to be on. They give you a half pound of pecorino. Pecorino is cheese that comes from up in the hillsides in Italy, in southern Italy. On the far right here, this is Norcia, where they sell quite a bit of pecorino. It is from animals that are fed from grass-fed. They're roaming around eating what they normally eat. It's from sheep. And what happened is individuals that ate this cheese had a 50% decrease in inflammatory marker IL-6, 22% decrease in IL-8, and then tumor necrosis factor was decreased from eating cheese, right? Which most people have heard, oh my God, cheese is high fat, it's going to kill us, et cetera, et cetera. Yet this study in humans shows that if you eat well-made cheese, it actually lowers 3 inflammatory markers that correlate with cancer. I got to speed up here, so I'm going to skip these. I'll make one more comment. There's 5 levels of evidence. 5 is expert opinions. Expert opinions are things like the food pyramid. This was the food plate. And these are things that just were utter disasters that weren't backed by science. They were backed by 3 people in a room that decided this would be a good idea to tell people to eat 6 to 11 servings of bread per day, which is like the Bravo special that could, fatten any of us up. And these don't go away. It's like I always talk about the 10% liquor tax from the Johnstown flood. We still pay that tax because of that flood. We still pay that on our alcohol. That was what, 1936. So expert opinions, this stuff, once the government puts it in, it never goes away. Randomized controlled trials are where we need to get our info. I'm going to finish here in 3 minutes because I know I'm supposed to leave time for questions. So what dose of exercise to improve the soil? What dose of exercise to make our bone density more dense? What size of exercise to increase muscle mass strength, et cetera? Again, not all exercises are the same. If you said someone needs to increase their quad strength because they need bone density or they need to increase muscle mass in their quads, you can look at a research paper and not know whether the person's doing this, sitting on a leg extension on the left where there's absolutely no stress on her spine or hips, the one in the pink tank top, or you could do a goblet squat, which is what most people at the Exercise Oncology Center do on Mondays for their first lift, where look at that, that's training your quads. It's also loading your spine, your hips, every bone in your body. Or you could be the crazy, amazing lady that I buy my raw grass-fed butter from, where she's probably 70 now, but she clean and press that overhead and is competing in the senior weightlifting competitions. That's a totally different type of exercise, right? So you need to hit a minimum essential strain, i.e. 10% of the stress that would cause your leg to fracture. You need to hit that amount to actually increase bone density there, and that causes dormant osteoblasts to migrate to that area. That's why you see things like this study on the right. This was comparing gymnasts in black versus long distance runners in the grayish versus controls. Gymnasts are spinning, flipping around, and smashing their lower extremities off the mat all day long. So they have very high bone density in their shins. Runners are doing the opposite, right? They're not pounding, they're just grinding out their lower extremities. So they actually have a risk of decreased bone density in their shins. Bone density correlates with strength. So the stronger you are, the more dense your bones are. That's why that line is going up. And there's similar findings with muscle mass. You have to hit thresholds. You have to do things like lift a certain muscle group 10 times per week to increase muscle mass. Now, that's not absolute, but you have to hit a threshold. You can't just go and exercise. You can't just walk. You can't just do 1 pound weights. Much like chemo dosing, our view is that exercise is not necessarily for home, especially if you're trying to really push things. In this study, this was actually shown, these are trained athletes, and those athletes that were sent home to work out, when they looked at their strength, they saw significant decreases in the empty circles, those individuals that worked out by themselves at home versus those individuals that worked out under expert guidance. They got stronger, they got more hypertrophy. You see that in the bottom here. So you get larger muscles if someone's watching you and pushing you. And so supported training is better than unsupported training. And in fact, data shows that if you're sent home to exercise, you have a coin flip, 50% adherence. So if we know that if you go home, you're probably not going to exercise, we want you to exercise under our roof. 27 studies show that. There's decreased adherence with fewer contacts. We want you in here interacting with people, no supervised element, no prescription, and limited social support. So if you're failing at exercise, it may be because of those 4 reasons. And again, one more slide. This is those 4 mechanisms for those individuals that couldn't see it when the screen was smaller. But again, resistance exercise, fasting, ketosis, etc., eating spices. We didn't have time to talk about sulfur and those kind of things. They all overlap in mechanisms and how they may help our bodies prune cancer cells. I'm going to skip through that slide because I know there's some questions. And when we think about that image of Puglia, the olive trees, this is our muscle mass. These are the olive trees. If we take care of the soil, they grow nice and large. And if we take care of the soil and decrease the adipose tissue, it stops the weeds from growing, right? We just have that one pocket of, this was in the fall, by the way, that's why they haven't flowered yet, but we just have that one pocket of flowers in the middle. And I think realistically, from a data point of view, we have data to say why this approach works. We don't have the data yet to say, can we stop the seed with our diet or exercise? And this is a clinic. Thank you very much. If anyone has any questions, we have 17 minutes left. Sorry, I sped up at the end there. I was supposed to keep it to 30 or 40 minutes.
Hey, Dr. Champ, it's Margie Leslie.
Hey.
I have one question that came in in the chat, which I'll read to you. And
Sure.
It says, does red light therapy help to strengthen mitochondria? Is it useful for someone being treated for cancer?
There's not any data to support red light therapy. Well, that's a lie. There's not data to support that question in terms of red light therapy. There is some data that it may decrease pain and have some other more quality of life based effects. But there's no studies to say that it would improve mitochondrial function or improve outcomes in cancer patients. There is hope that it could improve things because it's a pretty not toxic treatment, though there aren't long-term safety studies on it either. There are actually sauna studies that sauna can improve overall health. There are association studies with some studies from the Nordic areas. And so people extrapolate from the sauna studies. The issue is in those sauna studies, they actually didn't use red light. They used kind of old school kind of sauna. So the jury is still out. We may be running a study to at least answer the latter question. But for the former question, I know people are looking into it. The problem is red light therapy now is freely available on Amazon and other places. And oftentimes when that happens, people don't want to run those studies because if the studies are negative, then it could hurt their bottom line, which is an unfortunate truth.
Okay. Wanted to just ask, here's a few more questions are coming in. Okay, I was going to ask for additional questions. So here they come. Okay, so the next question, do you prescribe or recommend an individually tailored diet for patients in your program?
Yeah, so that's a great question. And, blanket dietary recommendations are obviously not appropriate. Personalized diet recommendations make sense. They just get a little more difficult. What we like to do, we have nutrition sessions. They're every other week. And it's just a group of individuals that have either been in the center or are in the center. And we sit down and just talk through and hash it out because a lot of people struggle with the same issues with nutrition. And I think those issues are what helps to tailor a nutrition program. So for instance, if you're trying to gain muscle and lose fat, which we should all be doing, and you keep overeating, but you overeat almonds, right? Which, like, you can't ever criticize almonds to a group of nutritionists or dietitians because they're like, no, nuts are the healthiest thing in the world. But if you can't stop eating nuts, because that's I don't know what you want to call it, a trigger food or something for you, then you probably shouldn't have nuts, right? So in that regard, I do think you should tailor it to the individual. And then if someone has a propensity to overeat sweets, carbohydrates, bread, pasta, etc., which I just define me or a lot of people, we view those foods as a drug, not food. If you think about food, you eat food for vitamins, nutrients, the building blocks of our cells. So if foods derail you from doing that, they should absolutely be avoided. If you can eliminate them from your diet, great. So all those things should be personalized. And then, of course, not eating through a reductionist strategy, but eating to eat food. So make sure you're getting enough protein, make sure you're getting enough vitamins. People that are constantly trying to restrict, particularly restrict calories, can oftentimes get in a lot of trouble with weight loss in an inappropriate way and muscle loss.
Thank you. The next question is, do people need a referral to come to this exercise center?
Yeah, just have your doc reach out to me. And this is under the current medical system. They don't even know how to deal with this type of scenario. So I've just had, docs reach out. At AHN, the physical therapist reach out as well. Some of the nutritionists reach out as well. So that's been how we're doing it.
The next question is, how can we learn more about diet and exercise?
It's a great question. So there's a lot of stuff online and a lot of it's not good. I would recommend, some of the things we talked about, certainly, how to maintain muscle mass, how to build muscle mass. I think that's a more important question to ask when you do online searches than like, what's the best diet or what's the best way to eat? Because you get all kind of opinions, and a lot of it's based more on dogma than actual science. Like take Willett for instance, right? He was trying to push a low-fat diet for breast cancer forever. Even he said, there's no data to support this. It needs to stop. If you look online, you're going to hear about it left and right. So look up what's the best diet to maintain or increase muscle mass, and then obviously to keep adipose tissue off. We have a website. Now it doesn't have dietary sources on it, but yeah, that's the best thing to do. There's a lot of stuff to sort through online, so it gets a bit complicated. I've written books on the topic. We're going to have a pamphlet of some sort coming out after our nutrition sessions, basically summarizing everything we talk about, because that question comes up so much. And the point of that is going to then provide you with direction as to where to go to find more answers.
Okay, I think we still have a few minutes. I can carry on with a few more questions if that's okay with you.
Sure.
Do you have any exercise recommendations for someone actively going through chemotherapy when they have depleted energy?
Yeah, so that's a great question. We have a bunch of studies looking at that. The bird's eye view comment is, the days you feel good, obviously in a safe environment. So we have exercise. So I'd love for you to, come on one of our studies. We have exercise studies where people on chemo, they come in because we want to maximize safety. And the days you feel good, we push you, right? And you might pay for it the next day, but the days you feel good are when you really got to push it. And then some days you're going to feel crummy. It's not linear, right? You're not linearly feeling worse and worse. You're not linearly feeling better and better. It's up and down. So the good days, you push it. The bad days, you don't. What I will say is the bad days, I would still do something, whether it's mobility drills, go for a walk, etc. But that's going to keep you positive. That's going to keep you going. And then when you feel good, you push it. We call them red light, yellow light, green light workouts. If it's a bad day, you get a red light workout. You just do mobility drills. If it's a good day, if it's an okay day, we do a yellow light workout. If you're feeling good, then we switch it to a green light. So I agree. You have to taper it based on how you feel.
Okay, great. Should you limit fruits to keep a low carb diet?
It depends. So at our center, if you're trying to lose fat, we have people go up or down on their carbs because overall consumption generally mirrors that. More fiber in your carbs, the better. So berries, blueberries, raspberries, fruits where you eat the skin and the seeds are going to be much higher in fiber. So you don't necessarily have to go nuts on those. I would save them till after a workout because you're a little more insulin sensitive. But things like tropical fruits where you peel the peel off, they have less fiber and a heck of a lot more sugar. Those can derail your adipose tissue loss goals pretty thoroughly if you over consume them. What I will say is if you're clean otherwise, so if you're getting adequate protein, good amount of fats in those foods, good green leafy veggies and colorful veggies, but you're still not shedding the adipose tissue, then you can play around and go up or down and then see how it goes. And then when you lose what you want to lose, then you can start, reintroducing some of those berries.
The next question is, do you think you should mix cardio with weight training or just focus on weight training after treatment?
Yeah, it's a great question. So the $1 million question is what's cardio, right? So for our, if you're one of the, we have all men and women working out at the center, but I'm going to focus in on my breast cancer ladies because that's what we have the most of. So if you're one of the women that come in and do one of our workouts that ends with pushing a 150-pound sled back and forth, pushing it and pulling it 30 yards, 4 to 5 times, is that cardio or is that resistance training? Because you're going to be out of breath. Your heart rate's going to be 160. The answer is it's both. And so what we try to do is we alternate between hypertrophy, strength training, conditioning. So we try to get the cardio in with the training. That way you get a bigger bang for your buck. If you go out and run 10 miles, you're not going to build muscle mass. In fact, you're probably going to lose muscle mass. But you can come in and we can put you through a resistance training protocol. I mean, we have one that goes boom, 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 boom from one to the next, where you will build muscle mass on a quote cardio conditioning regimen. So I'm very much a fan of that versus just chug it out cardio. Plus, for a lot of people, they just don't want to, run on a treadmill or, run outside for an hour at a time or 2 hours at a time. If you can get your heart rate up doing resistance training, I think you get more bang for your buck.
Okay, and I have one final question I'm going to throw out here before we wrap up. And this question is, are compound movements recommended over machine movements for bone density and overall muscle health?
So yes, superficially, the answer to that is yes. For bone density, absolutely. So, if we go, can everyone see my screen still?
Yes.
If we go back to this slide, I mean, there's literally studies where they put women like the pink t-shirt woman here on that machine and measured bone density after lifting. They measure on a DEXA, they measure your hips and your spine, and they showed no change. The reason bone density changes is because the bones are stressed. The bones actually start to fracture and calcium comes in and fills it in. If you're not providing that stress to those bones, you're not going to see a change. So the woman in the middle here, she's going to see that change. And everyone can do this. Now she's low, so maybe not everyone's range of motion will be that good, though you'd be surprised. And obviously the woman on the right is going to see huge bone density changes. But if you don't load those bones, you're not going to see a change. And if you don't load those bones with a heavy lift, you're not going to see a change. So if you're looking to increase your bone density and you're sitting on one of these machines, it's not going to work. If you're doing a hex bar deadlift, which if you're at our center, you'll be doing on Friday, you're going to load every bone in your body. That's going to be most effective. And it's the same for muscle. You don't have to do all compound movements for hypertrophy because machines can help to burn out the muscle. But we generally do compound movements first and then supplement them in with isolated machine type movements. So they both serve a purpose, but you have to be doing compound movements if you want to increase bone density. If you want to just move better throughout the rest of your life and increase your chances of staying upright, not falling, not breaking a hip, etc. Any other questions?
There's a few other, since it is, whatever time we got. Okay, I'll give you a couple more. Do you advocate swimming as exercise to build muscle mass and bone strength?
Swimming's great. It's not going to build any bone strength, bone density, and it's going to be tough to build muscle mass with swimming. Swimming's great. Walking's great. I think walking's like breathing, right? We should all be walking. We should not walk anywhere we can drive. Do I look to that to gain muscle, increase my physical function, increase my performance in life as I age? No, it's just not gonna help in those areas. I'm not saying not to do it. I think it's great. Mentally, it's therapeutic as well, but you're just not going to see as much bang for your buck in terms of hypertrophy and bone density.
Okay, and this will be the final question. How much protein per day do women over 50 need to gain muscle mass? Is there a formula based on weight that you might be able to share?
Great question. Really good question. And that is a very controversial topic right now. If you go to the guidelines from, I forget the name of the organization, they're insanely low. Realistically, what you need and what we all need, and particularly those of us who are aging need, is more protein. And those of us that are losing muscle mass or on a diet or losing fat mass need more protein as well. So what we likely need is 20 to 30 grams per meal if we eat 3 meals a day. That will help us to get adequate leucine. And then if we're trying to preserve or gain muscle mass, a good rule of thumb is to get at least 75% of your weight, your ideal body weight. So ideal. So, if you're overweight, you need to look up the ideal body weight for someone your size. 75% of your pounds in grams per day. So if your ideal body weight is 100 pounds, if you get 75 grams per day, you're going to ideally maintain or gain muscle mass. Now, again, this is controversial. Some people say a little bit less is still okay. Some people say even more than that is better. What I will say is if you resistance train, which I hope you all are, after an exercise session where you resistance train, you're much better at using protein and amino acids. So if you're not getting enough protein, load up after an exercise session. And it's another reason why you should resistance train. You should tear up and traumatize your muscles so that they pull in all that protein and amino acids to grow back stronger. And my last comment, the dirty joke of nature is all that stuff gets harder as we age. So you don't have to work out less as we age. Right, it's a lot easier to stay in shape when you're 18 and have a metabolism where you can eat a bowl of ice cream for dinner and still be lean. As we get older, we actually need more protein and more resistance training to make sure that overcomes what's called anabolic resistance. Yeah, great question. Great final question.
Great, thank you so much for a great presentation. And I'll turn it over to Ms. Ball to give the final closing instructions.
Thanks everyone.
Thank you, Margie, and thank you, Dr. Champ. That was very, very informative. If there are no other, actually, we do have more questions. Apologies that we couldn't get to all of them since we're out of time, but we would like to thank all of you for attending our Ahead of Cancer lecture this evening. Please continue to join us at our monthly Ahead of Cancer lecture series as we focus on cancer screening, early detection, treatment, and survivorship. As a reminder, tonight's lecture was recorded. If you are interested in rewatching tonight's lecture, check back on the AHN YouTube channel, www.youtube.com/Allegheny Health Network for the full recording in about a week or so. This video, as well as all other past lectures, will be posted under the Ahead of Cancer playlist. If you would like to schedule an appointment or have questions regarding a potential cancer concern, please call the Hope line at 412-578-4673 to schedule an appointment. Again, that was 412-578-4673. You may also call our 24-hour Nurse for You line at 412-687-4968. 412-687-4968. Thank you for the great presentation, Dr. Champ, and thanks to all who attended the lecture this evening. Have a nice evening, everyone.